Hello, everyone. While everybody's joining, we're just going to give it a few minutes for people people are still coming in. So we'll just give it a minute or two and then we'll get started. Okay, we'll kind of stop. So we'll get started since we just have an hour together and we want to make the most of it. But first of all, I just wanted to thank everybody for joining us. My name is Helen Crawford and I'm the Senior Programs Manager here at Psoriasis Canada. Want to thank you all for taking the time out of your evening to join us today for the first of a three-part series of webinars that we're doing for World Psoriasis Day. The theme this year is comorbidities. So we're starting with this one, which is more of a condition grouped into psoriatic disease, but is starting the first of our webinar series. Before we jump into it, though, I just want to do a few housekeeping things. This session is being broadcast or simultaneously translated in French. So the instructions are, if you want to listen in French, you just need to go to the bottom of your screen and select the interpretation button, and then just toggle to French. And if you don't want to hear the English, which would kind of be muted in the background, you can select to mute the original language, and then you'll just hear the French. So again, if you need to listen to this in French, just toggle at the bottom on the interpretation screen. Just to remind everybody, this webinar is being recorded in English and in French, and it will be posted for viewing on our YouTube channel after this session. So all of you will remain in listen-only mode during our guest speakers. And if you do have any questions, we ask them that you just type them, please, in the Q&A or into the chat box. And we have time at the end of our presentation to address questions. And any of the ones that we might not be able to get to, if time doesn't allow, we'll try to answer them afterwards and include them when we post this session to our webinar. To our YouTube channel. I just want to note that all of the information tonight in this presentation is for general information purposes only. For anything specific to yourselves, that you please speak to your family care physician or your dermatologist or rheumatologist, but all the information that we're presenting tonight is for general purposes. And we just want to take a quick moment to thank our supporters of World Psoriasis Day and this webinar series. That's AbbVie, Arcutis, J&J, Lilly, Sun Pharma, and UCB. So just a little bit about Psoriasis Canada. We are actually a consolidation of two previous organizations that have been operating in Canada since 2012. So the Canadian Psoriasis Network and the Canadian Association of Psoriasis Patients. And we consolidated into one national organization last year and are now Psoriasis Canada. Please be sure that you're following us on all of our social channels, because that's usually our main means of communication with our community. So all major social handles, and our handle is at PsoriasisCan1. You can email us if you have any questions at info@psoriasiscanada.ca. And we are in the process now of developing a brand new website that we're hoping to have launched by the end of this year, and it'll be at www.psoriasiscanada.ca. So with that, I just want to thank you all again for coming. And again, we'll address questions at the end, but I wanted to introduce you to our first speaker, who is Kerry Yang. And he is here to speak about his own personal experience with psoriatic arthritis. And Kerry is a medical student in Alberta who was diagnosed with psoriasis at a young age, and very recently has been diagnosed with psoriatic arthritis. And with that, I will pass it to Kerry to take over.
Wow, thank you so much, Helen, for that introduction. And thank all of you for participating with us and joining us for this talk. So as you mostly do have like psoriasis. It's a difficult like disease, especially when it's just like the skin, but psoriasis can go like more than skin deep, and I'm here to sort of like talk about that. So just a reminder to everybody to please avoid taking any pictures of my slides. So I actually did include some photos of my personal health information and just some things from like my medical chart here in Alberta. So yeah, just to like confirm again with like Helen, I am a medical student actually at the University of Calgary, currently on my clinical rotations. And I'm really excited to sort of talk about my personal journey with psoriasis and psoriatic arthritis. So yeah, I have no relevant disclosures to share for this presentation. So yeah, so growing up with psoriasis was something that I've had since I was 7 years old. So actually sort of started on my knees. My mom thought it was from sort of kneeling. So in like all the kindergarten classes I took part in, we would always sort of like kneel, and through like grade school as well, just with sort of, like mats and on the ground. And then I just started developing these sort of like plaques on my knees, and they were just really, really itchy all the time. I would constantly be scratching them all the time. And actually took like a couple of years before my mom brought me to sort of like a family physician, because she tried like a bunch of like different things and like different like traditional like medicines, and like none of them ever sort of like worked. So then we actually went to like a family doc who instantly knew what it was like right away. He was like, this is psoriasis. He saw him kind of like on my knees, and it was also on my elbows like at that time, but it wasn't like too bad. And sort of like at first, like my family doc at that time, he just like told my mom, okay, so what your son has is like psoriasis and it's not curable. And my mom, she's like a very stubborn person. If you've ever like met her, you would sort of kind of know. But she was actually kind of like taken aback by this news. She heard, oh, psoriasis is like not curable, and she started fighting like the family physician. And they like fought back and forth, but like in the end, what sort of like happened was like the family physician was like, okay, take this medication, just sort of like try it, see if it like works. And what he sort of like prescribed for me was sort of like hydrocortisone. So I'm sure like as many of you sort of have sort of been able to sort of tell with your personal journeys, like hydrocortisone, it's not a very strong steroid. It's on like the weaker end, it doesn't really do that much. And it also did not do that much for me. Like I tried it, it did not work. And since that point, my mom, she just started mistrusting like traditional Chinese, like Western medicine, and would only let me use like traditional Chinese medicine. So pretty much like growing up since I was like 11, I had used a bunch of like different creams, balms, or like drinks, like food that were all sort of like herb based, and none of them would ever work. So eventually I just learned how to sort of like live with my psoriasis, sort of like on my knees. My scalp was also really itchy. I had flares that did pop up in like different areas, but I was sort of like a bit lucky. It wasn't like too bad, as sort of like tell from the photo. I didn't have like too much of sort of like my body covered in the plaque. Then after I started medical school, I had my first flare. So pretty much like since high school, I started getting like back pain. I always thought like back pain was normal. I thought everybody got it. I thought it was just from like my backpack. But like looking back on it now, I realized, okay, maybe there was something else kind of going on. Constantly be getting like back pain and sort of like pain in my ankles and like my knees. But I never like really thought too much about it, because also at this time, like I sort of was living in like ignorance. I didn't really know what else was sort of associated with psoriasis. I just thought it was like a skin disease, and it was just that. And also my psoriasis at that point, it was like very poorly managed. Like nothing that I would ever kind of like use would ever like really work on like the plaques. So I just kind of learned to like grow with sort of all those silver flakes everywhere. But essentially, kind of like around Easter break during my first year of medicine, I actually sort of had my first flare. So I got a herpes infection in my eye, and I started getting joint pain in my fingers and my back. So by that time, I already learned about what psoriatic arthritis was in medical school. So like now I knew like you could actually develop arthritis if you have psoriasis. And it was at the back of my mind, but I was thinking, okay, it can't be like that bad. Like sometimes you can get joint pain after like an infection. Like I just needed to take a few Tylenols and everything was like okay. But then I had exams in sort of like March and June. And then I had another flare that started getting a bit bigger. It lasted a few more days. I needed to take some Advil. I needed to like layer on like a few more of those like painkillers to sort of help manage it. But then I had a very big flare in August. I would sort of like call that my first like major flare. That sort of like kickstarted everything for me. So pretty much like in that flare, it was miserable. So I started kind of like noticing like my back pain getting like worse and worse. And then my joints in my hands started to like hurt a lot. And I was tired all the time and I was sleepy and I just couldn't think with my brain. And I knew like something was going on. Like now I was kind of setting in, okay, do I potentially have psoriatic arthritis? Because I was meeting all the symptoms, I was having like the joint pain, I was having like the fatigue. I was sort of having kind of like pain in like my shoulders and my neck and everywhere like else in my body. And it was just really consuming. Like I wasn't able to sleep at night. It felt like I was constantly like running hot all the time. Sort of like having headaches. I was having like eye pain. And yeah, I decided to sort of like go to the emergency. And the thing is, kind of like at the merge, they kind of like listened to like my story and I asked if I could be like connected to a rheumatologist. And they were essentially kind of like, you know what, like you're fine, you're young. It's probably like not that bad. Because like again, like I'm 25, I'm in medical school, I'm still a student, and we have something in like medicine that we call like medical school syndrome. It's essentially when like a medical student sees a new disease, they think that they have it. And I think the emergency doc did think that that potentially could be the case because he didn't really believe me when I was sort of like telling him about like all my symptoms. And in the end, he told me, "Oh, you probably have like anxiety or like insomnia. It's fine, just like sleep it off." But I tried sleeping it off and nothing changed. So I went to like my family doc and I got lab work and everything came back normal. Again, this is probably a common story that you sort of might hear. Like nothing necessarily might show if you do have psoriatic arthritis, and that happened to be the case with me. Like we ran everything, we ran like sort of like HbA, like B27, we ran sort of like ANAs, we ran like all these sort of like different inflammatory markers and other things just to look for clues, but everything was all regular, it was all normal. There was nothing that was showing on my lab work. So I was really lucky because I had a dermatologist who taught us in class, and I sent her an email, and she was able to actually see me like sort of the same week. So again, like we chatted, and like again, like psoriasis, it's like pretty mild. I also had it under control with some topical steroids, so it wasn't like very active, and there wasn't like any like large glaring signs that I had like arthritis other than like all the pain and the fatigue I was going through. But she still was able to help me get seen by a rheumatologist within like a week, which is like pretty difficult in like Canada given how many people need to see like rheumatologists and how long the wait lists are. So I got in, I shared my story again, and what my rheumatologist sort of like told me is like, actually, I think you might have like fibromyalgia. Since I was just having so much like pain and so much like tenderness sort of like everywhere, like everything just like hurt. That was what sort of like the picture was sort of like pointing at. But he still let me like order some x-rays and they did it sort of my hands as well as my spine. And in my spine, like with like my SI joints or like sacroiliac joints, the joints along kind of like your lower back, there was signs of sort of like sclerosis in like both, which means it's like signs of like damage. So the thing is, like if you're young, the only things that should be causing that, it's like a massive infection. It's like if I got into like a car crash, I was an Olympic athlete, or it's an inflammatory arthritis. Since I didn't have any massive accidents, I'm not an Olympic athlete, I didn't have any big infections that like hit me, just it was quite clearly psoriatic arthritis. And that was sort of like the diagnosis I was given. But like what people thought was like it wasn't too bad. That's what my rheumatologist and I thought at that time. But it's also like quite common for just like a lot of people with like joint pain and like psoriasis to have something that we call like diagnostic delay, as in it takes some time from symptom onset before you actually get a diagnosis. Again, like I was extremely lucky. I was seen very quickly. I had sort of something on my x-ray that very much pointed towards psoriatic arthritis or inflammatory arthritis. But for like a lot of people, like if you aren't able to sort of get seen quickly, the average amount of time it does take is actually 6.5 years from the time you first get that joint pain to before you get the diagnosis. So thing is, like, I was just on sort of like NSAIDs, like painkillers for the most part. But then I actually had my first clinical rotation where I was like helping deliver babies. And I just entered into like a massive flare. Like after a couple of days in, like all my joints started hurting. Like I was just exhausted. My back was killing me. I wasn't able to sleep at night. And I would actually like drive home from every shift in like tears just because like my back and my feet were in like searing pain. And I actually had to take medical leave from medical school just to get started on like biologics for like injectable medication. It was a really tough decision for me because I just come from like a family that pushes really hard, and I'm also somebody who's like quite ambitious and like pushes really hard. So to actually take like the leap and to take time off was a really big decision for me. But in the end, it was like undoubtedly the right one. Like I needed to take that time off to like stop my flaring because at that time I was like mixing like two different sort of like painkillers, which you should never do. But I was doing it because the pain was so bad. I was using like Voltaren on top and sort of like topical medication. And I was also using like my steroids to sort of like help stop like all the pain just to make things like feel better. But after sort of like getting started on sort of like my injectable medications and biologics, like everything changed. Like I feel so much better. Like I can actually get through a day without like any pain. Like I just finished a work day and like have very little symptoms now, and I'm just very grateful that that was sort of like the case for me because again, like it doesn't always happen for like a lot of people. This like next slide. So with that, that sort of like brings me to like the end of like my story. Like I think kind of like the biggest sort of like takeaways from this is it can be very difficult to like get a diagnosis. Like psoriatic arthritis, it's something that we call it's a steronegative disease. That means it doesn't show on like lab work and like doesn't always show like on imaging. And like sometimes you have to like search very hard. And that makes it very difficult for people with psoriasis to actually like get a diagnosis. Again, I was just very lucky because I was very much connected into the system. But there was like multiple times in my journey where like even I wanted to like give up and I didn't want to like keep fighting anymore because like pretty early on, I kind of like knew what it was, like deep down inside. I was like, I'm quite sure this is like psoriatic arthritis, but actually to sort of like fight for it is quite like difficult. And especially since like a lot of rheumatologists and a lot of doctors practice very differently, it can be very difficult to find like advocates in certain situations. So yeah, I'm happy to take questions at the end. If you do need any like help or support, my email is like there. You're always like welcome to email me. Like I'm sure like maybe like a few of you might be in a similar situation as I was. And if you do need any help and support, please just shoot me a quick email and I'm happy to reply and help you.
Great. Thank you. Thank you so much, Carrie. I think it takes a lot of courage to be able to do this and share your story. So we're really grateful for that. And if there are a few questions in the chat, so we'll put them on hold till we get to the end of the presentations. But thank you again so much for sharing. So next, I'd like to introduce you to Dr. Vinod Chandran, who is a rheumatologist, and he's also a clinical scientist at the Krembil Research Institute, the University Health Network. He's a professor of medicine at the University of Toronto and holds the Dr. Daphne D. Gladman Chair in Psoriatic Arthritis Research at UHN. He is an expert in psoriatic arthritis and directs the Gladman Krembil Psoriatic Arthritis Program at the Schroeder Arthritis Institute. His translational research program is focused on developing biomarker-based diagnostic and prognostic tools for psoriatic arthritis, with support by grants from the Canadian Institute of Health Research, the National Psoriasis Foundation, the Arthritis Society, and the Krembil Foundation. He has published more than 250 papers. He's also an elected member of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also known as GRAPPA, which is an international organization facilitating research and education on the diagnosis and treatment of psoriasis and psoriatic arthritis. He's on their board of directors and is also its co-vice president. So we're very fortunate to have Dr. Chandran here to present on psoriatic arthritis. So I'll pass it to you.
Thank you so much, Ellen. And I'm glad you're all here today. Can you hear me well? There was some questions about the sound. So if you can hear me well, I'll go ahead. So the theme today is about comorbidities, and I was reflecting on one of my patients. We had a discussion yesterday. In addition to reminding me to wear these green glasses today, she said that the term comorbidity was so what should I say, jarring, or felt very if you think about it, comorbid condition, it sounds really morbid, right? So what is, comorbidity is a medical term, but it essentially means associated conditions. When you have a particular condition, you might have other conditions associated with it. And that's what comorbidities are. And here we are talking about comorbidities that has come along with the psoriasis, which is a predominantly skin condition. And an important one is psoriatic arthritis, just the story that you just heard. But I'd like to kind of talk a little more about this so that we all understand and how we can then hopefully recognize it early and treat it well. So these are my disclosures. I do get support from many of the pharmaceutical industry partners in this field, as well as the research grants that was just mentioned. My wife also works for AstraZeneca. So when I talk about treatment, you might want to take it with a pinch of salt. Okay, so what is psoriatic arthritis? In simple terms, it's a type of arthritis. It's an inflammatory arthritis associated with psoriasis. So I can go deeper into it. But before doing that, I thought I could discuss, or at least describe, a few cases from my practice, kind of showing the various manifestations, or the different types of psoriatic arthritis that can happen. And because the definition, as I just mentioned, is just says inflammatory arthritis, of course, when you do that, we have ruled out other causes. And then we say, oh, the pattern does look like this condition. And so we make the diagnosis. And so sometimes it's a challenge because there are no diagnostic tests. And these cases would illustrate that, just like what Kerry had just mentioned. So case one, this is usually very typical. It's usually somebody in the late 20s or 30s who has had psoriasis for some time. So this particular guy had psoriasis for about 7 years. It was mild, didn't really bother. And then gradually developed joint pain in the hands, the knees, and had a great family doctor, was referred quite quickly when this happened. And we in our clinic noticed psoriasis in the typical sites, the elbows and knees. There's also nail lesions. That's an important sign, because if you have psoriasis and nail disease, then you might more likely have arthritis. And then there was swelling and tenderness in the hand joints, particularly the BIP, the joint next to the nail, in the fingernails and even toenails, but toenails are always hard to assess. And then left knee was swollen. The blood work was largely bland. The CRP was 6, with 5 being normal, so slightly elevated. CRP is such a non-specific marker of inflammation that it goes up and down all the time. And so was not considered that important. But given the physical examination, a careful physical examination showing swollen, tender joints, especially the DIP joint involvement, it was a given. You didn't really need further testing or X-rays or other things, because X-rays are also not very sensitive. The disease has to be present for some time, cause some damage for it to show something, right? So the physical exam is actually the key thing. And unfortunately, only a rheumatologist who's been properly trained are good enough to kind of elicit the appropriate signs, and which again is one of the reasons why the diagnosis gets delayed. In any case, the diagnosis was made, was treated with a conventional drug, did really very well for many years, as is often the case, especially with early diagnosis. The skin got better, the joints pains were much better, but still present. One important thing that he mentioned was that whenever he kind of put extra pressure on the joints, for example, by lifting weights or such, the knees swell up. He would come to the clinic, would inject, but things were, so it was grumbling along, not gone, but still quite much better than before being on treatment. In our cohort, we do X-rays periodically to look for joint damage progression because that tells you how good the inflammation was controlled at. After about 9 years, we noticed that some of the joints in his hands, especially, were beginning to get damaged. He still had some swollen joints. And at that time, we switched to one of the targeted therapies that was available. And immediately, he had significant improvement. The pains were not present anymore. And most importantly, there were no flares after, exercising and those kind of things, and has done really well since then. So it's a great success story and a typical case. Now I'll talk about another case. A slightly more older woman, came from quite far away. And in many ways, this history reflected what Kerry just mentioned. Had very mild psoriasis, never really diagnosed. Nobody even mentioned it whenever she went to for assessment. Had progressive joint pain beginning in the 40s. Had difficulty in walking. The feet and knees were hurting. And the knee joint got really bad so quickly that within a few years required knee replacements. So when you have such a rapidly progressing, presumably regular arthritis or osteoarthritis, you want to be a little suspicious, right? The challenge was that the ESR, the CRP, the inflammatory markers are all negative. You typically, when you go to a family doctor and say, "Oh, I think I have joint pain, maybe I have rheumatoid," so you do this test, and if everything comes back negative, the inflammatory markers are normal, rheumatoid factor is negative, you're like, yeah, maybe it's osteoarthritis. Lose weight, exercise, take some anti-inflammatories as the usual, advice, and which sometimes is a problem. Like in this case, she was on anti-inflammatories, didn't really help, and when was finally seen by us, we noticed that there was mild psoriasis. So there was nail disease, but really no psoriasis. She gave a history of having psoriasis some time ago, but there were swollen joints, and there was what we call enthesitis, where there is inflammation where the tendons or ligaments attached to bone. And as you can see, as I mentioned, the knees were replaced, so there's a lot of destruction there. If you look at the feet X-rays, there were damage in these joints in the midfoot, which is not usually looked at carefully, and the hip joints were terribly damaged. And so this again indicated psoriatic arthritis, given the type of damage that you can see. But more importantly, the diagnosis was made before the X-rays because you could actually see inflamed joint. And the history was quite dramatic with such destructive arthritis of the knees, the hips, and the foot, but not the hand joints and not the toes, etc., were typically found. So one important message is that the blood test could be normal. You need a good physical exam, and joints that are sometimes difficult to assess can be involved. And all arthritis of the hips or knees is not osteoarthritis, even if the blood work is normal, right? So this is really important to know. Then it's not just about joints. Psoriatic arthritis can affect structures around the joints, what we call enthesis, and so that causes pain in and around joints. But when you examine the joint, you don't find anything there. So then you might think, oh, this is fibromyalgia. Kerry mentioned that. So this case, this was somebody in the pharmaceutical industry. He knew all about advanced therapy, psoriasis management. He had very severe psoriasis since age 18, never complained of joint pain, didn't really do well with treatment. And then with the conventional treatments, and his dermatologist treated him with a new targeted therapy. This was in 2015, so a lot of options were available, and the skin cleared. And then he came and said, "Oh, you know what? I don't have any joint pain." So the dermatologist said, "Well, you never complained of joint pain." He said, "Well, I didn't know, because prior to being on this treatment, getting up in the morning was difficult. Going down from his bedroom and on the first floor, so on the top floor, what do you call it in Canada, second floor, going down the steps to the first floor was very difficult. And it would take about an hour for things to get better, and then he would forget about it. But that early 1 hour was quite difficult. The feet used to hurt a lot. The ankles, mainly around the ankles, the heel bone, the plantar fascia, the elbows around, but he could move it well, but it was really hurting. And that improved over. And when those symptoms went away, he realized, oh, I did have what we say enthesitis, where there is inflammation, where the tendons and ligaments attached to bone. And that you can see on ultrasound or MRI, as in these pictures here. So that's another form of psoriatic arthritis. And lastly, there is this 50-year-old man who had lots of psoriasis. We have a cohort in our center where we recruit patients who don't have arthritis, and we follow them over time to see if to understand why some people get arthritis and some do not. And when he came, he said, oh, he has no arthritis. He wanted to take part in the study. We said, oh, very good. I was examining him, and his back was really not moving very well. He didn't really complain too much of back pain. He's just, everybody says they have some back pain, especially when you reach about 50. But given the restriction in mobility, I got x-rays done, and these x-rays show what Kerry mentioned, sacroiliitis, inflammation of these joints there. And so he had psoriatic arthritis involving the joints of the back, or sometimes called axial psoriatic arthritis. So these cases are just to illustrate how it's not straightforward. It's a challenge, sometimes even for rheumatologists, but especially for a dermatologist or a family physician to make that diagnosis, and especially because there are no simple tests that you can do to say, oh yeah, this increases your likelihood of having it. So the awareness of this could be a possibility, and then having a low threshold for referral or assessment is really important to make that diagnosis. And I'd like to also emphasize that the psoriatic arthritis has a lot of manifestations in addition to the psoriasis. So we can have inflamed joints, like I mentioned. This is the joint I mentioned in the first patient, where that it was the joint next to the nails, the DIP, distal interphalangeal joint, can be inflamed and can be quite red. And so that's one manifestation. The biggest challenge is that many of the joints that are affected are also affected by osteoarthritis, which is a mildly inflamed form of arthritis that happens with, I shouldn't say age, but with wear and, overuse and with age, associated with age. And so that's the most common form of arthritis. By and large, most people with arthritis have that form. And so when somebody complains of joint pain, especially when you're older, the first thing that the family doctors or rheumatologists think would be, oh yeah, this must be osteoarthritis. So then we have to evaluate to see if that inflammation in the joint is mild, like osteoarthritis, or more than what you would expect, and therefore could be psoriatic, right? So that there's a lot of judgment involved. So you can have involvement of these joints in the hands, the DIP, the PIP joints. You can see the typical redness that you can sometimes see with the joints. It can affect the heels. So we talked about enthesitis, difficulty in walking early in the morning. It can cause what sausage digits, like the fourth toe over here, the whole toe swollen like a sausage, and then the back involvement. So these are the typical manifestation of psoriatic arthritis. It can affect any joint, so all the joints have to be carefully evaluated. Don't forget, most people have psoriasis, mostly mild to moderate, but sometimes very severe. Nail disease, where we have pitting or sometimes lifting and yellowness of the nails. And when you have that, you tend to have, you're more likely to have psoriatic arthritis. So it's an important sign. There can be inflammation, not just in the skin and joints, but also the gut. So inflammatory bowel disease, you must have heard of Crohn's disease. It's quite much more prevalent in patients with psoriasis than those without that, than the general population. Can have inflammation in the eye. So I was just wondering, as Kerry was talking, was that actually a viral infection, herpes in the eye that you mentioned, or was that actually conjunctivitis or uveitis related to psoriatic disease? And then problem, another big important comorbidity is the metabolic syndrome. So weight is intimately associated with psoriasis. If you're overweight or obese, you're more likely to get psoriasis. And if you have psoriasis and obesity, you're more likely to get psoriatic arthritis. And obesity is also associated with less response to treatment. So really need to address that when we think about psoriatic disease. And what I just mentioned until now was all about, what we as physicians are we have a label for it and we can test for it and look for it and are confident talking about. But there is a lot of things in the background, which we really don't assess in the clinic, right? There is the huge impact, depression, anxiety, the embarrassment, the pain, which we ask for it, we ask questions, but we still don't experience it. And so um, it may be hard to get that message across sometimes when you have so much of pain, and sometimes the patients feel dismissed when they complain of pain. Uh, when you ask the physicians what is most important, we talk about, oh, how bad is the psoriasis? How many swollen joints? Is that joint damage? But when you ask the patients what is important, they're like, oh, the pain, the fatigue, let's talk about that. And so you can see that we are not really talking about, we're talking about the same condition, but what what we think is important is the things that patients say, well, that's okay, but what about my fatigue, my pain, my function, and work productive, how to work. Of course, there is financial burden, an important issue with social participation, intimacy and sexual relationships, etc. So it's the impact of the disease, the burden of psoriasis, psoriatic arthritis is huge. And so the quality of life is something that we all need to really pay attention to. And I think over the last few years, with more advanced therapies, there has been significant improvement, but the challenges remain. And constantly in the clinic, despite being on advanced therapies, the main conversation is about persistent disease activity, persistent pain, persistent fatigue, and how to manage that. Now, what is the relationship between psoriasis and psoriatic arthritis? Most people get the psoriasis first and then the psoriatic arthritis. That's about 70%. And 15% it happens around the same time, within the same, say, calendar year. And then 15% the arthritis happens first and then the psoriasis. And the psoriasis may not even happen at all. So when you only have the arthritis and no skin disease, that adds on a bigger, another layer of complexity, right? Because see arthritis inflammation, you don't see skin, then you're thinking, what kind of arthritis is it? Maybe it is rheumatoid. So you kind of misdiagnose. Some of the drugs that you use that are useful for psoriatic arthritis do not work for, that are used in rheumatoid, does not work for psoriatic. So you're on the and then when the drug doesn't work, immediately you think, oh, maybe it's just osteoarthritis, and that's why, because the blood work is also kind of bland, right? No, so that's a big challenge. And the other important point is that the psoriatic arthritis can happen anytime after the onset of psoriasis. It used to be believed that, if the arthritis had to occur within the first 10 years, more and more research shows that it can happen anytime. As I mentioned, could be before the psoriasis, after, and the risk is constant. And so it does not change over time. And you can even get it 30, 40, 50 years after the onset of psoriasis. And the trigger, what causes it, that's a good question. We know some triggers, but not all. And therefore, if there is a suspicion, a proper evaluation and follow-up is really what is required. So once you have psoriasis, you might get psoriatic arthritis. Are there some indicators that might help? Not many, but things to consider would be the severity of psoriasis. If you have more severe psoriasis, you're more likely to get it. Although the number of people with severe psoriasis in the larger population with psoriasis is not that many, but if you have severe psoriasis, you're more likely. I mentioned nail psoriasis, nail pits, lifting, yellowness, yellowing and lifting of the nails, some spots on the nails, all that are important markers for psoriatic, that puts you at higher risk of getting psoriatic arthritis. And then sometimes specific sites like folds, the scalp. Some people believe that if you have those kind of psoriasis, you're more likely to get it. But I think most important is that when you have psoriasis, it's to kind of keep that in mind, that maybe the joint pain, especially if it is persistent and with associated significant fatigue and pain, then think about psoriatic arthritis. I mentioned obesity and metabolic syndrome, so that's another risk factor. And of course, these conditions have a strong genetic effect. And so if you have a family history of psoriatic arthritis, that's another thing to consider. What are the early symptoms? Pain, of course, and we call the inflammatory kind of pain, which is usually worse after periods of inactivity. So early in the morning, typically. And then when you get up and you feel painful and stiff for some time, and then actually as you get active and move around, exercise, things get better. That's inflammatory pain as opposed to mechanical pains, typical of osteoarthritis, where you're okay after resting, and then when you exercise or do work, you get more and more pain. So the pain is more towards the end of the day. If, as I mentioned, if you have new or worsening unexplained fatigue, think about psoriatic arthritis. And then if you're seeing nail changes, again, maybe psoriatic arthritis is developing. To help in trying to diagnose psoriatic arthritis early, we have looked at screening questionnaires. Many people have developed this. And so if you screen positive for psoriatic arthritis, this is one example of a questionnaire. Not important to go through it, but ideally your primary care physician or your dermatologist should be asking you, hey, is there any joint pain, stiffness? Have a quick look at the joints to see if there is something. And if there is a questionnaire that you can do and there is a suspicion, can go to your family doctor and say, I think I might have psoriatic arthritis. Do refer, and don't bother with blood tests, because that might be normal, and it'll be better for you that you need a proper physical exam of the joints rather than a blood test. As I mentioned, how you diagnose it, it's by a rheumatologist. It's by careful clinical exam. That is the key. Blood tests, if you find inflammation, okay, but the blood markers of inflammation could be normal. X-rays, if it is normal, does not rule it out. Ultrasound has to be done very carefully by experts, so it's not really something that an ordinary ultrasoundologist or a rheumatologist or a clinic can do. And MRIs have to be properly assessed. So that'd be better done at centers where they have expertise in doing it, rather than getting it at a local clinic where they might not have seen a lot of X-rays of people with psoriatic arthritis, or not X-rays, but MRIs or ultrasounds with people with psoriatic arthritis and other spondyloarthritis. There's no diagnostic tests. So again, blood tests are not very useful for diagnosis, and it may be present without psoriasis. So that's, especially if you have a family member who have joint pain but no psoriasis, do keep that in mind. Because it's important, because early diagnosis would lead to better treatment response, less joint damage, better physical function, quality of life, and lesser comorbidities. And the early treatment and better control of inflammation and pain early would prevent the long-term chronic pain that is a big problem that our patients who are diagnosed late have. How do you manage? Education is important. Sessions like this, where we can discuss general health measures, really important. Exercising, stopping smoking, weight management, good sleep, stress management, yoga and meditation, all that are really good. And of course, if there is persistent inflammatory disease, you need to be on treatment to reduce that inflammation. Conventionally, we start treatment just for immediate symptom relief with anti-inflammatories. We don't generally give corticosteroids because they have a lot more side effects, and most people, as I mentioned, also have metabolic syndrome, obesity, that can get really worse with steroid therapy. But injection into the joints when a few joints are inflamed are helpful in reducing the inflammation quickly. And then we use immunomodulatory therapy. There are these conventional drugs like methotrexate, sulfasalazine, leflunomide. These are effective early in a subset, but it's we usually typically start with one or two of these drugs, and also many of the insurance programs require that we try these first before going to more expensive therapies. And then there are advanced therapies. Thankfully, now we have many options. There are the anti-TNF mentions on the left. There are about 5 of them. And then we have cheaper biosimilars, which are equally good. So that's great. We have a lot more options, lesser costs, so that more people can be treated. We have these T-cell guided therapies called abatacept. We don't use that much. It's not great for psoriasis, but does help some people with psoriatic arthritis. But again, that's usually not used as first line. The Th17 pathway blockers listed here is ustekinumab, which blocks IL-12/23, or guselkumab and risankizumab, which blocks IL-12/P19, and the IL-17 blocker secukinumab, ixekizumab, and bimekizumab are really recent, have come to us from the last decade or so, and very effective. And we have some effective oral treatments, targeted oral treatments like apremilast, which is less effective, but lesser side effects. And the JAK inhibitor is much more effective, but potentially more side effects. Everything has that balance, right? If there's every drug, there's a potential risks and benefits, and we have to look at what's best. And the treatment is to reduce inflammation to the lowest level possible. We need to look at all aspects of the disease. I've illustrated a few. We really have to manage other comorbidities. And then when you make a decision, you have to have a conversation between the physician and the patient and make individualized treatment recommendations. I won't go through this schema, which for physicians to choose which drug is best. And the bottom line is that you look at the peripheral joints, the back, the enthesis, dactylitis, psoriasis, nail disease. If there is IBD, inflammatory bowel disease or Crohn's disease, evaluate that, and eye disease, evaluate that. Get help from the dermatologist, get help from the gastroenterologist and the ophthalmologist, and then look at all the manifestations to see what is the most problematic, target your treatment to that, but also considering other domains if they're affected. So it's not just based on the skin or just not based on one joint, but the whole inflammatory aspects. Because there are very few drugs that help all these manifestations, and some drugs may help the joints, but may worsen the skin, or may help the joints and worsen if you have gut inflammation, that could be worsened. So you have to be very careful on choosing the right drug. What can we do to get outcomes better? Awareness, early diagnosis. I talked about that. And then when seeing your primary care physician or dermatologist, always mention the joint pain or pain around joints and ask for a referral. And so when you go to when you're referred and you're seeing a rheumatologist, everybody's busy. So when you go there, you can go with your symptoms and say, these are my joints that are affected. I had sausage digits in these joints. I have back pain. I have heel and elbow pain, indicating enthesitis. If they're very busy, you can say, wait a minute, I need a proper exam. I'm willing to, disrobe so that you can have a good look at all my joints, my enthesis, and examine my skin very carefully. Take off your shoes and socks to show them your feet. The plantar fascia is important. The toes are really important. Many times the disease is over there, and if you don't examine your feet, you might miss the diagnosis. So that's really important. And then when you go, also talk about all the other diseases that may be present, like if you're taking treatment for diabetes or depression, for example. And if you have medications that you've been on, be good to give them especially if you've been previously treated for your psoriasis or for your arthritis, what drugs you have taken and what is the start and stop dates were and how you responded. So all that information is really important. And that by doing this, I think the physician would be more careful in evaluating and you can build a better therapeutic relationship and hopefully make the right diagnosis and treatment soon. So to summarize, I think I took a little more time than I anticipated, but it's important to remember that psoriatic arthritis is an inflammatory condition. The diagnosis requires careful evaluation of rheumatologists. So the dermatologist has to do a good job, do a proper assessment. And as a patient, if you're prepared for it, then when you go, then you should also insist that you're properly evaluated. I mentioned disrobing and taking your shoes and socks off in addition to other things. And then really good treatments are available, and they're more effective when you make the diagnosis early. And that shared decision between the physician, the patient, and all the other specialists, as well as your primary care, is really important in getting good outcomes in the long term. With that, I'll stop, and I can have good conversation, questions. Welcome.
Great. Thank you so much, Dr. Chandran. And just quickly to apologize for any feedback issues at the beginning. It was hard to kind of see your comments and talk at the same time. So if anybody was having trouble hearing me, I'm sorry for that, but hopefully you had no problems listening to Carrie and Dr. Chandran. I have enabled the chat, so if you do have questions, you can enter them into the chat, but we do have a few as well in the Q&A that were put there. So firstly, Dr. Chandran, can you, I think you touched on it briefly, but can psoriatic arthritis affect the Achilles tendons?
So yeah, so it's not that. So at least tendinitis is a common condition, especially if you're, um, depending on how you walk, etc. There is inflammation of the tendon sheath. That's common, and that's not very specific for psoriatic arthritis. What is important is the Achilles enthesitis. So it's not the tendon, but where the tendon attaches to the bone. So at the bottom of the tendon where it attaches to bone, that's what is more specific for psoriatic arthritis. So not the tendinitis, but the enthesitis. And sometimes, you can have both and it's really close together, right? So good clinical exam, but also to really look for psoriatic inflammation. In such situations, the best modality would be a proper ultrasound evaluation and sometimes even MRI, but ultrasound is good enough. And so it's enthesitis, which is specific, although tendinitis can happen, but it's very hard to say if the tendinitis is just there because it's a common problem or is it due to the arthritis.
Thank you. And again, there's a couple of questions that are very specific to a person's personal treatment journey. So we, I'll just ask kind of a general question that kind of relates to one, but a patient's been having trouble getting diagnosed, was previously diagnosed with psoriatic arthritis in another country, and was treated with ibuprofen for a long time, and some other treatments. Over the past 9 months, they've been experiencing severe debilitating pain in spine, neck, heel, and hip. Recent tests show negative C-reactive protein, negative HLA-B27, and no inflammation on an MRI. The rheumatologist does not believe it's psoriatic arthritis due to the absence of visible swelling in their fingers. What other tests or diagnostic approaches would you recommend to confirm?
Yeah, it's a challenge when the problem with the back, especially, right, is back pain is common and many reasons for it. And the most common form of back pain is what we call non-specific or sometimes mechanical back pain, where there's no real mechanism, but it's due to the non-inflammatory causes that we have back pain, and that can be quite severe. Now, in psoriatic arthritis, there is inflammation, and I try to talk, the pain, that the inflammatory kind of pain is usually with rest and gets better with activity, and but nothing's very set in stone about how to differentiate the two. So we really look for inflammation using MRIs. Now, the of all the tests for evaluating the back, the MRI is really important. And in psoriatic arthritis, the CRP may be normal, the HLA-B27 may be negative. So those are not, if it is positive, it's helpful, but if it's negative, it does not rule out. But the MRI becomes really important. And but there are many ways of doing the MRI and many protocols, but there are specific protocols for evaluating the spine, which my answer would be if the MRI has been done appropriately and reviewed by experts. Not all radiologists or rheumatologists are experts at looking at the spinal MRIs. So ensuring that a proper protocol has been done and then evaluated by people who know how to read it would be most important to rule out inflammatory disease in the spine. And so when you go back to your rheumatologist, one thing to confirm is that the appropriate protocols were done and that somebody with expertise, because in the rheumatology and radiology training programs, how to read these spinal MRIs are not typically taught. You need to have additional training for that, right? So there might be a lack of expertise. So that is something to be ensured. And if by doing all that, if there is no evidence of inflammation on MRIs, then the likelihood that this is due to psoriatic becomes lower. Although it is true that sometimes you can have inflammation in the spine that's not detected by MRI. That's possible, but hard to diagnose it without actually seeing that.
I can also talk to this as well, just because it does sound like a bit like my story and like what I kind of like went through. So I think just also to like elaborate like a bit more, like actually like something that really confused me for my journey was just the fact that like a lot of the imaging by like radiologists so reported, okay, like I guess it could be, but like we can't say for sure. Like there's no like definitive signs. But after I talked with like some of my friends on radiology, like actually like learned like in sort of like Calgary, they don't see like a lot of kind of like psoriatic arthritis. There's no kind of like specialists who are really good for kind of like inflammatory kind of like MSK or like the musculoskeletal system. Like a lot of them, they usually see like arthritis, and that's kind of like what they're used to. And the thing is, like everybody actually does have like a little bit of arthritis in like the joints. Like if you image any of us, you're gonna sort of like see some damage, and that's perfectly normal. But sort of what they do in Calgary among like the radiologists here is they just assume, okay, that's probably normal. It's probably just arthritis. And because of that, I do think that they miss quite a bit of people with like inflammatory arthritis and like those kind of like issues. So like something that I would kind of like recommend is just to ask for something called like a second read. So see if you can like switch radiologists and get like a different interpretation of kind of like that read, and sort of see if somebody who actually specializes in like inflammatory arthritises, especially psoriatic arthritis, because it does present differently, can read it. Because like when you sort of like mentioned in like the chat, erosion of your hip, that doesn't really happen with like osteoarthritis. That's not like a big telltale sign. If somebody has like erosive osteoarthritis, that's much rarer than just like normal osteoarthritis. So something's already kind of like going off in my head. And the thing is, like the other thing that you sort of see with inflammatory arthritis is on like the bone spurs is because it does attach like those enthesial like points, those like attachment points. You actually do see like little kind of like bone spurts on like the spine and like all different parts of like your body, because that's kind of like where the inflammation is centered. So again, that's also something that's more classically seen with like inflammatory arthritis. So I would sort of say like the picture is like a bit mixed. It's not like definitively not. So again, like just getting like a second read, seeing if you can get like different interpretations, I think is the first thing. Another avenue that I would kind of like recommend is like if you do sort of have like psoriasis on your scalp and psoriasis kind of like in your like pelvic area in your genitals. Well, recently the International Psoriasis Council actually changed the definition of what like moderate to severe psoriasis is. So now actually it includes kind of like your like more sensitive areas, so your hands, your feet, your scalp, kind of like your genital area, and that actually does count as like severe psoriasis. And you actually can sort of like increase like treatment to one of the biologics, which will help with like the psoriatic arthritis. Oh, that's another way in which you can like tell if you actually do have psoriatic arthritis. If the biologics work for your joints, you probably have psoriatic arthritis. Like it doesn't help like osteoarthritis at all. So even just doing like a trial run and seeing if it like works is like a strategy that like some rheumatologists use, not all of them do. But again, like I think just getting different perspectives is going to be really important, and making sure like you do get an accurate read on the condition and trying different like strategies, because like I tried so many different ways to get my diagnosis.
Great, thank you, Carrie. We do have several more questions, but unfortunately, we're out of time. So if our speakers will agree, I will send you the questions, and perhaps we can summarize some answers to be sent out, like I mentioned at the beginning, and we'll link them when we post the webinar, and we'll also just send out a follow-up email with some of those answers to the questions, because they started coming in quickly and we've run out of time. So with that, again, I just want to thank both of our speakers for joining us today. Thank you to everybody who took the time this evening to be with us. I've dropped a feedback form in the chat. If you could please take a few moments to fill that out, we'd really appreciate it. I've also put in a registration link to the next session that we're doing on October 29th, which is about the mind-skin connection. So looking at the mental health impacts of living with psoriatic disease. And on November 6th, we'll also be hosting one on cardiovascular disease and metabolic syndrome, like Dr. Chandran had mentioned, one of the associated conditions of psoriatic disease. So again, thank you everybody so much. And we'll try and get that information out to you in the next few days. And enjoy your evening. Thank you.
Thank you, everybody. Thank you for joining.
Thank you.
Thanks, everyone.